Good afternoon, everyone. My name is Michelle Brunson. I'm a Health IT Advisor with Telegen for the Small, Underserved, and Rural Support Quality Payment Program Resource Center. Presenting with me today is my colleague and friend, Sandy Swallow, the Quinn QIO Program Specialist. Sandy works with groups of 16 or more clinicians and larger health system ACOs. Thank you for joining Sandy and I as we discuss the Quality Payment Program looking ahead to year 2. We value your opinion, so in the next day or two, we will send you a short questionnaire. Please complete this questionnaire so we receive important feedback and also ideas for future webinars. Today, we'll start by touching on some of the key policies of the 2017 Quality Payment Program as the basis for comparison for the changes proposed for year 2 of the Quality Payment Program in 2018, both surrounding the merit-based incentive payment system and the alternate payment model. Then we'll talk about how you can submit comments to CMS on this proposed rule. As you know, the Quality Payment Program was established under the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA. MACRA was a bipartisan legislation in an effort to increase focus on quality and value of care, moving toward a more patient-centric healthcare system. The main goals are to improve patients' health outcomes while spending wisely. CMS wants to minimize burden of participation, so that is why they are combining their legacy quality programs into one with the Quality Payment Program, or QPP. We're shifting away from a system of only paying for volume to a system that rewards value and outcomes. 2017 is year 1, and so to help minimize the burden, it is the transition year, with much flexibility built into it to help clinicians succeed in how they choose to participate in the program. You'll see that much flexibility continues into year 2 with the proposed rule. Quality Payment Program, or QPP, has 2 tracks, the Merit-Based Incentive Payment System and the Advanced Alternative Payment Models, or Advanced APMs. For MIPS, most clinicians will participate in this path initially because they participated in the traditional fee-for-service Medicare Part B, not tied to value or quality. MIPS replaces the Physician Quality Reporting System, the Value-Based Modifier, and Meaningful Use into one. And the final score is calculated from the quality data by the eligible clinician in 4 different performance categories. Eligible clinicians will receive that payment adjustment on the Medicare Part B Physician Fee Schedule in 2019 as a result of their submissions in 2017. By participating in the APM path, provider reimbursement moves further in the advanced APMs from the fee-for-service payment model to models that tie payment to value. And so in these advanced APMs, providers band together generally to operate under an APM. Accountable care organizations would be an example. And there are some specific requirements that need to be met that have increased financial risk for providers and organizations in the APMs. So as a result, there's greater opportunity for rewards. And the participants receive an additional 5% lump sum annual bonus for participation in an APM. So flexibility really is the key term for the 2017 transition year. And you will see as we talk about the year 2 2018 proposed rule that CMS keeps a common theme of flexibility with many of these policies. First of all, MIPS eligible clinicians in 2017 have the opportunity to pick their pace by submitting data at the level they feel comfortable submitting, whether that's a minimum amount of data to simply avoid the negative 4% payment adjustment in 2019, or if they want to submit 90 days of data to potentially receive a small positive payment adjustment in 2019, or up to a full year of data for 2017 transition year, and they may receive even more of a moderate payment adjustment. Second of all, there are exclusions from participation in the Quality Payment Program. In 2017, if the eligible clinicians fall below the low-volume threshold that exempts many of these clinicians with a low volume of either Medicare Part B payments or patients. And if the eligible clinician significantly participates in an advanced alternative payment model, they're also excluded from MIPS. We'll talk about these differences later in the webinar. And finally, there are additional flexibilities for clinicians who are in small practices of 15 or fewer clinicians, or if they are in an underserved or rural area. Also, there are more flexibilities for those eligible clinicians considered to be hospital-based or those that have limited face-to-face encounters with patients. So as we begin to discuss the Year 2 proposed rule in 2018, I'm going to turn this over to Sandy, and we're going to really dive into these a little bit deeper. Sandy?
Well, thank you, Michelle, and thank you for the overview of what's happening right now for all of us in 2017. This presentation going forward, we're kind of assuming you have baseline knowledge of the quality payment program in general, but we will be happy to address questions at the end, too, about the 2017 performance period. But the changes and updates that we're going to be discussing with the proposed rule would be effective January 1st, 2018, and they do not change anything for the current performance period. So the first year of QPP, or Quality Payment Program, has been referred to as Pick Your Pace and the transition year, but CMS is going to refer to the second year as the Quality Payment Program Year 2. So Michelle and I, we've been wondering how the Quality Payment Program was going to look going forward, and I think the proposed rule gives us kind of a early indication of how it is going to evolve. For this session, we dove into it and we decided that it would make sense for us to kind of categorize the changes and the updates. And so I'm going to start with the general policy proposed changes and updates. You're hearing, or we've heard lots of talk and conversation about virtual groups already, you know, from the transition year. And the proposed rule added virtual group participation as another option for clinicians. Virtual groups would be composed of solo practitioners and groups of 10 or fewer NIPS-eligible clinicians who come together virtually to participate as a group, regardless of their location or their specialty. Now, the opportunity for this is an opportunity for small practices to join together across organizational teams to create a single group for the purpose of MIPS reporting. They would report across all four, and the final score would be calculated across all four performance categories, costs not being included, you know, for the 2018 period if they end up making it at 0%. So if you are a solo practitioner or in a small group, this gives you the flexibility to join with other clinicians. You'll need to elect to participate in a virtual group prior to the start of 2018 performance year. We don't know exactly how you're going to elect to do that yet, but in the final rule that comes out this fall, they will have more guidance on that. But you should start your conversations now with other clinicians that you might feel you want to join with. Personally, I've been on a number of the CMS feedback calls for virtual groups, and it really still is not entirely clear how this is going to be administered and how it's going to shake out. So I'm anxious for what comes of the final rule after we get all the comments from this rule. Also, if you are a non-facing clinician, you are eligible to be part of a virtual group, or else form your own group of all non-facing clinicians. Moving on, I think that there will be some folks that really like this next proposal. They're allowing the use of multiple submission mechanisms within a performance category as it's available for that performance category and applicable. But you can use different submission methods to meet the requirements of the quality category, the ACI category, and the IA category. And they're also allowing a more lax reporting period for the advancing care information and the improvement activities to a minimum of 90 days, just like it is in the 2017 performance period.
So, Sandy, do I understand you to say that the quality category, if I had 4 of my 6 quality measures where my EHR does have the capability to submit those 4 measures for me, I could do so and then still use the claims for the other 2 measures that my EHR doesn't have that capability? So that way I can maximize my bonus points for the end-to-end reporting using my EHR for the 4 measures?
That's exactly what I'm saying, Michelle. Very good. That's a great example for folks out there. And we've had lots of questions even for this year if they could use more than one submission method for a particular category. And I think because of all those questions, I think CMS is looking at that a little better, and that's why it's proposed for 2018.
Great.
We are seeing some relaxing of the eligibility with the changes in the low volume threshold. They recommend increasing the threshold to exclude individual MIPS eligible clinicians or groups with less than or equal to $90,000 in Part B allowed charges, or less than or equal to 200 Medicare Part B beneficiaries during the low volume threshold determination period. So that's quite a relaxing from 30,000 and 100. We'll see that more clinicians will be exempt from MIPS, but most likely those will not be clinicians in the mid-sized or the larger groups. Now, starting with 2019 MIPS performance period, it allows clinicians to opt in to MIPS with low volume, if you're a low volume clinician, for what they call a third component. So besides the Medicare revenue and the number of beneficiaries, the CMS is proposing that in 2019, adding a third item in which they're seeking comments on, and that third item is looking at the number of Part B items and services. And this is just an opt-in option, so I'm not really sure how significant that is, but more to come on that one.
So, Sandy, what's the likelihood then of the low volume threshold increasing in Spain? What are your thoughts on that?
Well, personally, I was surprised that it was supposed to be this relaxed at the $90,000. There's just been much conversation about how this would give too many practices a pass on transitioning to the value-based payments. CMS really did an estimate that was in the proposed rule that said that with the new exclusions, they figured out how many exclusions that would be, that 65% of the Medicare Part B payments will be captured in the MIPS program, which was down from 72.2% in 2017. So not really a big change, even though it will be a lot, several more clinicians, payment-wise, it's not a big change. Well, I really expect that the low volume threshold, if it comes, it'll come down over time as the program matures, and then it'll start to bring in those folks that meet the low volume threshold for 2018.
Very good. Well, thank you. Okay, well, I'm going to start talking about quality and the proposals for the year 2. One of the bigger changes for the quality category is that they're proposing 12 months of data to be used for quality. So you'll start 2018 with the data being tracked right away and to have your submission method in place to make sure that you're able to do so. And so another one of the proposals that I thought was quite significant is that CMS is looking to reward improvement in performance in the quality category with bonus points. And so CMS would score improvement at the performance category level rather than measuring improvement at the measure level. So this would allow improvement to be available to the broadest number of MIPS eligible clinicians because they are connecting performance to previous MIPS quality performance as a whole rather than changes in performance to individual measures. CMS really wanted eligible clinicians to be able to adopt new measures without concern about losing the ability to be measured on improvement. So they're encouraging the clinicians to select more outcome measures and to move away from topped-out measures. And so therefore improvement could be calculated with the different measures. And CMS is allowing up to 10 percentage points for this improvement. So if you, let's say, increased your quality score from 50 percentage points to 60 percentage points in this next year, you'd have a 20% increase there, and then you'd multiply that by 10%, or you get 2 percentage point increase. So a 20% rate of improvement is worth 2 percentage point increase. The 10% point cap would represent 100% improvement, or doubling those points from the immediate preceding period. So that's quite a significant percentage points available for that, and it's really intended, I think, to help those who maybe didn't perform as well, in 2017.
Yeah, and that really changed their processes, recognized that they needed to do better, now as performance really matters, and recognized the benefits that they have created for their patients and themselves.
Absolutely. Absolutely. So another big category proposal for quality is that they're going to still keep it at 60% for the weight rather than what they were thinking about decreasing that a little bit. But one thing to note, and this is something that I think sometimes flies under the radar, is that in 2019 the quality category needs to be and must be decreased to 30% because it's written in the law that cost does have to be at 30%. So that's where it would be made up from here as this quality category. So a good year again in 18 to score well by scoring high on your quality percentage point. And then finally, CMS is looking at the data completeness threshold to remain at 50% for 2018. Now, they will give 1 point for measures that don't meet the data completeness threshold, but for those small practices, they get to still continue to receive 3 points if they don't meet the data completeness, and that's really where that flexibility comes into play. They're going to keep the 3-point floor for measures that are scored against benchmarks, so they will score at least a minimum of 3 points. And then also if the measures don't have a benchmark, they get 3 points, as well as those that don't meet a case minimum. And then they are looking at changes to the CAHPS for MIPS survey collection and scoring. As you remember, the Consumer Assessment of Healthcare Providers and Systems, the CAHPS for MIPS, they are looking at removing 2 summary survey measures, one in helping the patient take medication as directed. They just found that not to be reliable. And then another between visit communication, and removing that just to maintain consistency with the Medicare Shared Savings Program, which uses the CAHPS for ACO survey. So CMS is also seeking comment on adding 5 open-ended questions for patients to answer about their experience in that CAHPS for MIPS. So another something to think about. And then topped-out measures. They are looking at proposing a life cycle for topped-out measures, which after the measure benchmark is identified as topped out in the published benchmark for 2 years, in that third consecutive year it's identified as topped out, it'll be considered for removal through the notice and comment rulemaking, and it may be removed from the benchmark list in the 4th year. So CMS isn't proposing to remove the topped-out measures for 2018 MIPS performance period because there are currently a large number of topped-out measures, and removing them may impact the ability of some of the eligible clinicians to submit 6 measures overall, and also impact some specialties more than others. So they are proposing a cap score of 6 topped-out measures at 6 measure achievement points. So this way, those topped-out measures, they can easily be predicted by eligible clinicians, and they'll incentivize the clinicians to submit other measures than those that are topped out, so they can earn and improve with their improvement points. And those 6 measures that they are looking at for this 6-point cap, they are on Table 21. And, for example, one of them is perioperative care selecting a prophylactic antibiotics, or there's another for optimizing patient exposure to ionizing radiation, for example. But those 6 measures are on Table 21 of the proposed rule. And in 2019, they're proposing to apply special topped-out scoring to all topped-out measures, provided that it's the 2nd or more consecutive year it's identified as topped out. So they jumped from 6 measures in 18 to all measures in 19, that they would, instead of getting 10 measure achievement points, they'd get 6 measure achievement points for those topped-out measures. So a lot going on with that.
Oh, yeah. So I got a couple quick questions before you move on to your next slide. So the topped-out measures, you said Table 21. Do you have a page number for that for folks?
Yes.
You can look at that list?
Yes, that's on page 313.
Okay. Great. And then the other question is, can we talk a little bit more about that case minimum? I think a lot of folks are a little confused about how does the case minimum work.
Sure.
Can you?
Sure, absolutely. The denominator for the measure that's selected needs to be 20 or greater to be benchmarked for the decile point scoring. And so that's when you hear the case minimum, that's the denominator needing to be 20 or greater. But if you need to submit a measure with less than the 20 case minimum, you will still get your minimum 3 points. And so that's more that flexibility in trying to get folks able to submit measures. And especially if the only outcome measure that you have is below 20 cases, report on it, because then you get your 3 points.
So you don't get a negative for not submitting your outcome measure. You just aren't going to get up to 10 points, but at least you'll get 3 points.
Exactly.
And that score for that category. Okay.
Right.
All right.
Right.
Okay. Because I think that could happen to a lot of folks on
Yes.
these outcome measures if they don't have over 20 cases, especially if they're in a small group or they're doing individual reporting.
Especially with the folks that I work with in small underserved and rural, you bet.
My larger groups have, don't have as much of a concern with that as your folks. Okay,
absolutely. You bet. And then for more proposals for the quality, they are looking at implementing a voluntary facility-based scoring mechanism based on the hospital value-based purchasing program. So what this means, this is a new option for the quality and cost performance categories that allows facility-based MIPS-eligible clinicians to be scored based on their facility's performance. CMS believes that facility-based measurement is intended to reduce reporting burden on those facility-based MIPS-eligible clinicians by leveraging their existing quality data sources and value-based purchasing experiences and aligning the incentives between facilities and the MIPS-eligible clinicians who provide those services there. They were concerned that the definition of a hospital-based clinician, those that perform more than 75% of their services in an inpatient, on-campus, outpatient hospital or emergency room setting, that they could include many clinicians that have limited or no presence in the inpatient hospital setting. So they're proposing to determine a MIPS-eligible clinician's quality and cost performance category score based on the hospital's value-based purchasing program performance. And the measures in this program are focused on care provided in an inpatient setting. So CMS doesn't believe it's appropriate for a MIPS-eligible clinician to use a hospital's value-based purchasing program performance for MIPS scoring if they don't provide services in that setting. So they want to establish a different definition for purposes of facility-based measurement, and they're using that for this option. And CMS is proposing that a MIPS-eligible clinician is considered facility-based as an individual if the MIPS-eligible clinician furnishes 75% or more of their covered professional services in inpatient or emergency room. And those measures are adopted for the fiscal year 2019 hospital value-based purchasing program on the MIPS list and quality cost measures. Those scores that they use will be the facility where the clinician treats the highest number of Medicare beneficiaries, and there is a participation through opt-in or opt-out for the facility-based scoring.
Okay. All right. Quality. There was a lot of things going on in that quality category in that rule. For the advancing care information category, they had some changes in the rule that really allow it to stay the same as it is in 2017. Such as they're allowing for the minimum 90-day performance period again. That's the minimum reporting period. Categories to earn a maximum score for that particular category. Different from the original expectations. Originally, in the final rule, they had said that for 2015, for 2018, you'd have to be on the 2015 certified product, and they're changing that. They're allowing the use of 2014, 2015, and or a combination of those for the certified EHR technology health system that you're using in year 2018. That's a lot of years there, but however, there's still benefits for using 2015 certified system due to they're doing an added scoring bonus points for folks that in the year 2018 report that for the ACI category that they have used 2015 certified product and used the ACI options, major options set. They're going to give them some scoring bonus points. So there is obviously a reward for using it. However, you can stay with the 2014 or 2015 combination and actually still use the transition measures in 2018. Now, new to the ACI category is they've added a new hardship exception for clinicians in small practices where they will reweight the ACI to 0% and then push that weighting over to the quality category, similar to what they are doing this year for the hospital base. They also added a reweighting of the ACI to 0% for the ambulatory surgery center. Let's see. Continuing with the ACI category proposal changes, they did make some changes to two major specifications, the e-prescribing and the HIE measures. They've added the low volume thresholds of less than 100 exclusion. So if you are prescribing less than 100 prescriptions, then you are able to use that exemption, and also if you have less than 100 transitions of care, then you can use that exemption. You can earn a potential 5% bonus for up to 2 of the public health or clinical data registry options. For 2017, you got 5% for 1 or any additional clinical data registry. But for 2018, you get an opportunity to earn 2 for 2 of them, so 5% for each, or 10 additional percentage points. Now, if you're one of the unfortunate ones where your vendor decides to decertify, they are adding a decertification exception application for the ACI category only.
Now, Sandy, can you explain the exclusions that are being made available in the proposed rule? Will those take effect this year in 2017 then?
Well, that's a good question because this summer CMS updated all of the major specifications and they added, so you might want to go and look at all those if you haven't looked at those since I think it was the end of June. They've added a lot of the terminology and definitions and things like that, but in the e-prescribing measure, they went ahead and added that exception or the exemption for the less than 100 prescriptions written. Then you can put not applicable and take an exemption. But for the HIE, they did not add that for 2017, so that's being added for 2018. And I don't know what their thoughts were on that and why they didn't, or if it was just an oversight. But it is not in the for 2017. But if a eligible clinician takes the exclusion for the e-prescribing as a null value, the calculation of the score, they're not penalized for not taking it because the calculation of the score goes down by that much for the total.
Oh, that's good.
Yeah.
Okay. Great. Well, thank you. Well, so now let's talk a little bit about the improvement activity category proposals. It will stay the same, a minimum 90-day performance period. They are looking at, you might hear something about appropriate use criteria or AUC, and this is a new activity that they're looking at adding. It is the hope that the MIPS eligible clinician would attest that they are using a specified applicable appropriate use criteria through a qualified clinical decision support mechanism for all of their advanced diagnostic imaging services ordered. And that just means that the qualified mechanisms will be able to provide a report to the ordering clinician that can be used to look at the patterns of image ordering and improve upon those patterns to make sure that patients are receiving the most appropriate imaging for their individual condition. So this is a high-weighted activity, and you'll hear some more about that. So I just want to draw your attention to that. And then they are looking at adding 20 more activities and also changing some existing activities. So there is a list on Table F of page 1037 of the new improvement activities. And some of those activities include, for instance, the CDC training on CDC's guidelines for prescribing opioids for chronic pain. We've heard so much about opioids. And another would be completion of the CDC training on antibiotic stewardship, advanced care planning, among many others. So take a look at that, again, on Table F of the proposed rule. And then Table G makes a list of changes to about 26 existing activities. And many of those changes are just clarifications to make the activity easy to understand or provide more guidance. But there are some changes I noticed where the weights will change from high to medium or vice versa. So also take a look at those, and that's something that you might want to make note of for proposing a comment to CMS on those. For instance, they're looking at decreasing the weight from high to medium for TCPI participation or providing 24/7 access. And then also going from medium to high for leveraging a qualified clinical data registry to promote use of patient-reported outcome tools. So I found that those two lists pretty interesting, what they're looking at adding or changing. So take a look at those, again, tables F and G. And then next, they are looking at expanding the definition of a certified patient-centered medical home to include the comprehensive primary care plus APM model. And then just to clarify that the terms certified and recognized are the same, so they would both count there for the improvement activity for full credit. And then lastly, this one I thought was interesting. They're looking at increasing the threshold to 50% of the number of practices in a TIN that must be recognized as a patient-centered medical home to receive full credit rather than just one practice in a TIN. So, again, more opportunities for comments for you.
Well, that last one doesn't surprise me at all. I think you were pretty lenient this year with patient-centered medical home recognition if you were reporting as a group. All right. Oh, let's look at our favorite category, the cost category proposals. CMS is really looking for more feedback on the proposal to relax the cost category score to 0% for 2018 because they'll be moving it to 30% in 2019. So according to the MACRA legislation, that legislative act, they made recommendations for 2017 and 2018 weights, and that's when they decided to go with 0 and 10%. But the law requires that the cost be at 30% for 2019. So unless there is a legislation change, that's going to be a big jump. So they're wanting to hear what you folks are thinking out there. Should they keep it at 10% or, even though they know a lot of what they're doing with costs is still up in the air? They are proposing an improved scoring methodology for the cost category, and that would include only 2 cost measures, the Medicare spending per beneficiary measure and the total per capita cost measure. Those would be the 2 eligible improvement, those would be the 2 for anyway, at least the 2018, 2019. Both of those have been around a while, so they think folks are familiar with those, and they might be easy to start with those. The Medicare, just for a reminder here, the Medicare shared per beneficiary, the MSBP, includes the charges attributed to inpatient stays per beneficiary that are attributed to a provider or group with the plurality of the inpatient charges, where the total per capita cost, this is the annual cost per beneficiary, kind of the global healthcare cost for the beneficiary, and it's attributed to a single provider. Now, MIPS eligible clinicians could see their performance on each cost measure and better understand how the practice improvement changes can drive for each specific cost measure. They're thinking that might be easier to start with. CMS expects to replace some of the previous or the current episode-based measures with some newly developed ones. They've been working on that this year also. They think that these new ones will be more pertinent to our outpatient conditions and care. They're proposing to reward for improvement in performance. They would calculate a cost improvement score, and that's only when the data is sufficient to measure improvement. The way I understand it is they would use the same identifier in 2 consecutive performance periods, and it's scored in the same cost measures for 2 consecutive performance periods. And if the cost improvement score can't be calculated because they don't have the same measures for the 2 performance periods, then, there's not sufficient data. They're proposing to just assign a cost improvement score of 0, so you won't get a negative for that, but you just don't get the bonus points or the rewarding points for seeing that improvement. They're hoping for comments on that also because they're wanting your thoughts out there. And Michelle's going to tell you how to make comments here before we get done today. To address one of the biggest complaints about all the quality initiatives, and that's not just the QPP, but all quality initiatives, the biggest complaint is that certain providers are have more difficult and complex patient populations. So when they're looking at scoring, I'm not sure how this one will do in the comment period, but they propose that there will be benefits for providers with complex patient populations. And clinicians and groups can earn up to 3 bonus points on the final score based on the complexity of their patient population. And the proposal is that they would use the hierarchy condition codes, the HCC risk scores, which we're familiar with, they've been using for years. They would use those scores to determine this bonus. We talked a little bit, Michelle talked a little bit about the performance improvement scoring for quality performance and the facility-based scoring mechanisms. So those are just some updates and changes to the scoring proposal that we're talking about in this slide. Now, the performance threshold is one requirement that is increasing. So we've seen a lot of relaxing of things and continuing of some of the same things, but one thing that is increasing is that performance threshold. So to avoid a negative payment adjustment, you must have a final score of 15 points, which is up from 3 points in the transition year where you could just do that quick test option. Now, the exceptional bonus performance, it will continue at 70 points. This jump from 3 to 15 points will definitely make it more challenging in 2018 to avoid the payment adjustment. However, I think if you stop and think about it, you could even, if you receive full credit for your improvement activity category, which is 15 points, or if you're an advanced APM, it's 20 points, you would avoid the payment adjustment right there by just doing the improvement category.
So, Sandy, would you agree with all of the flexibility for clinicians in small practices that are proposed? Shows that CMS understands the burden this program can be on small independent practices?
Oh yeah, I definitely agree. And this has always been one of their goals. They don't want to push all practice, they don't want to push all these small rural solo practices into large systems if that's not what those folks are desiring. And so they've added these new hardship exemptions or exceptions for clinicians, such as the bonus points for the final score if you're in a small clinician, or awarding them measures in the quality category if they don't meet the data completeness requirements. I think they really are not favoring, but they're really looking at the small practices and not wanting to create more burden than they have to for them.
Absolutely.
Great. All right, moving on to the alternative payment model proposed changes and updates. There's not a lot of changes for this track, but I'm going to give you a few highlights. They're keeping the current stated standard amount, which previously was finalized that they would keep that amount through 2018. Well, now they're going to add 2 more additional years. So through 2020, they're going to allow an APM to meet the financial risk criterion to qualify as an advanced APM where their participants are required to bear a total risk of at least 8% of their Medicare A and B revenue. So they're not going to, not only will it stay for 17 and 18, but it's going to stay all the way like that through 2020. They're changing the nominal amount standard for the medical home models. So the minimum required amount of the total risk increases more slowly than what it was anticipated to be. And then also the round one CPC Plus participants are exempt from the requirements that the medical home standards only applies for those with less than 50 clinicians. Continuing with the advanced APM, CMS is giving more detail about the all-payer combination option and how it will be implemented. Clinicians will be able to combine revenue that flows through their Medicare advanced APM with revenue that flows through other commercial payers. This option allows clinicians to become qualifying participants, or QPs, through a combination of the Medicare participation in the advanced APM and the participation with other payers. Now, this option will be available beginning in 2019, but you need to start to consider that now because clinicians will need to ensure that their contracts with these other payers reflect the guidance for the all-payer combination advanced APM. Lastly, they have identified a fourth snapshot date of December 31st, so not just March, June, and August, but December 31st. This fourth snapshot period will be added for the purpose only of determining participation in full 10 MIP APM. Okay, so MIPS APM. So that fourth snapshot date will not be used for QP determination or to extend the QP performance period. It's just going to be used to identify new MIPS APM participants. So that's December 31st.
Great. Well, thank you for those updates as well, Sandy. And we've been talking a lot throughout the webinar today about your comments. And it's really important for you to understand that they want to hear from the healthcare community on the proposed policy in year 2 and its implications for you as clinicians in your offices. So there are different ways to comment on the proposed rule, and the different ways can be found on page 2 of the proposed rule, but the way that I actually think is the easiest is to do this electronically, and we have a link on the next slide here to show you. And these comments are due by August 21st, so 18 days away from today, August 21st by 5 p.m. Eastern. And there is a link here if you would like to submit your comments electronically, and we will have these slides up on the Telligent QPP website within the next 24 hours. Our marketing department's really good about getting those out there, so you could just click on that link, and it takes you right to the proposed rule where it takes just a little bit for the window to open. You give it a little bit of time, and then you can comment now and just enter your comments there, and it will go right to CMS. And I also think it's important to note that they will literally look at every one of those comments and they address those in the final rule. If you've ever read even part of the final rule, you'll see that they'll discuss a comment was made on ... and this was our thoughts behind it. So it's really important to go out there and give them your feedback on both what Sandy and I have talked about today, as well as anything you might see on, there's a fact sheet, and the link is here, and it really breaks it down into a nice format, a table format of what the 2017 current rule is and what the proposed rule is, so you can kind of get a better idea of anything else that you might want to comment on, and please do so. It's so important to make those comments. And then finally, there's a link here for the actual proposed rule itself, and like I said, if you'd rather submit your comments via regular mail, right on the inside of that proposed rule, it tells you how to do that. So please take time to look at those, but especially that fact sheet is very helpful.
All right, well, we want to just kind of sum it up with some takeaways today. Really, like I said at the beginning, Michelle and I've been kind of wondering what this is, what the QPP program was going to look like going forward, since they'll be making updates every year. And I think we see that the program is generally following the expected course. We see a rise in MIPS performance threshold to 15, but they're offering more opportunities for clinicians to improve their scores with bonus points, for the complex patients, using the 2015 certified system, multiple exceptions for the small practices to earn extra bonus points. With the new low-volume threshold exclusions, more clinicians will be exempt from MIPS, but most likely this is not going to include any of the mid-size or larger groups or anybody associated with it in an ACO. We expect more guidance and activity around the virtual groups and the all-care combination for the APM. So what does this mean to you? What does all this mean for you? I think it means tracking and reporting will be critical, especially in the quality category. As Michelle said, that retains the 60% weight, most likely in 2018. You're going to be reporting for 12 months in 2018, so that tracking and reporting is going to be significant when they're looking at performance and improvement scores. I think the reduction of small practices, the rural health clinic providers and clinicians via the low-volume threshold changes, mid-size and large groups will be competing against each other for some of that money, for the further enhancing the need to ensure the improved performance and reporting of your data. If you are in an advanced APM, you definitely want to start talking to your payers regarding the all-payer combination, really trying to get those discussions going. And if you are a solo or small group clinician, you want to consider, would it be to your benefit to participate in a virtual group and get those conversations going. But lastly, I really think it's time to prepare for the cost measure. I know that most of this is an influx with which cost measures will they be, which episodes, how many episodes, and then how is that going to be applied. But most of what is in the final rule and in the proposed rule, the guidance is pretty tentative yet. But if you can get your hands on your QRUR report that will be coming out this fall for 2016 and start to compare that with some of your previous reports. I know our Telegen QIO September Coffee Talk series, Courtney from Colorado, she is going to be giving a presentation on how to better understand your QRUR. She's doing a lot of work on this, trying to break it down so it's easier for us to explain and easier for you to understand. So please join us for that if you can. I think really that kind of sums up what we think it means for you guys moving forward. So we're going to open up the phone lines, and we'd love to hear any questions that you may have and see if we can help answer those. So one moment, please, while I unmute all the lines.
The leader has unmuted your line.
So we'd love to hear from you. Thank you so much, too, for joining us today. Does anybody have any questions based on anything you've heard today or something else that might be of interest to you? Okay, well, we have our contact information here, so please don't hesitate to reach out to us if you have any questions. Like I said, we're going to post our slides on the TelegenQPP.com website under the resources. So look for those either this afternoon or tomorrow. And We appreciate everything, any input that you could provide to us when you do receive your questionnaire. That really helps us in planning webinars and helping us and decide what we could do better or what you like. So thank you for that in advance, and have a great day.